Good morning, all of you.
Conference will now be recorded.
Hi, guys. Hello, can you hear me?
Yes, sir.
So, how are you? So, can you see the screen?
Yes, sir.
Okay, today, two light topics given to me, so we can do it very, very leisurely. Okay. I think how many of you are here? 116. Anybody else is coming, or actually that's the usual attendance? Jyot, Pawan, look after
Sir.
the attendance. So this may be my last class for you as 8th semester people. By the next time I see you, you will be promoted, isn't it? You will become 9th
Yes, sir.
semesters. So best of luck. So given to me are breath holding spells and enuresis.
ఫిల్టర్ దొరకట్లేదంట తెచ్చుకొని రోజు వెనక్కి పోతుంది.
There is some cross talk I see. One second. The breath holding spells and enuresis both come under guys, because there is some cross sound are coming, I just unmuted. If you want to speak anything, you can unmute yourself. Okay, all of you know how to unmute. So the topic given to me is breath holding spell. These are all come under behavioral disorders. Behavioral disorders is itself a big chapter actually. What do you understand by behavioral disorders? The definition of a behavioral disorder is any young person is said to have a behavioral disorder when he or she demonstrates a behavior that is noticeably different than that expected in the school or community. So there is no fixed thing actually. If you what is expected of you, and if you deviate from that, all those things can become grouped under behavioral disorders. There is a very broad spectrum definition. Okay, so you have to confine to the norms of the society, what you are expected to do, and if you deviate, there is something wrong. So that is behavior noticeably different in the expected school or community. That's it actually. So a child who is not doing what adults want him to do in a particular time. So it is like a adult's world almost. If you are not confining to the adults' expectations and thinking, you can be termed as a behavioral disordered person. Okay, but we are not that true, isn't it? So we can broadly divide the dysfunctional behavior is another term for behavioral disorders, habit disorders, conduct disorders, emotional disorders. That is a broad classification. Okay, habit by just habit. There is nothing purpose. There is no purpose actually. It is just out of your habit, like thumb suckings and all these things like stem. Conduct disorders are much more serious. Actually, something to do with the behavior. It's a much more serious offenses, especially the truancy and delinquency. All these things actually, it is in the forensic department. You must have heard of all those things actually. Emotional disorders. So there is a deprivation. Actually, there is a various dietary habits changing actually, and depressions and all these things, emotional disorders. So under this, now just watch this show. What happens? The sequence of events. This is a breath holding spell. Child first cries. Usually, after you they want something and you deny it. Then the cry leads to a period of what you see, holding of the breath, and then may turn blue, then may turn limp also. And this is followed by a tonic and few clonic moments. This type of description happens. When it happens, we call it a breath holding spell. This comes under one of the habit disorders. Actually, the temper tantrums and all these things come together under this. I don't know why they have separated. So they asked me, we'll ask to talk about breath holding spell. We'll confine to that. Breath holding spell is considered by many to be an attention seeking behavior. Actually, the temper tantrums where they suddenly child wants attention, that is more of attention drawing. But breath holding spells are not intentional. Please understand, this is not a attention seeking behavior. They result from involuntary reflex. The child doesn't know at all what is happening. Without his knowledge, child goes into this spot. Child has no ability to control. They cannot control it all. It is a probably a maturation problem. Maturation of the brainstem, and that may be something to do with the myelination, and this may lead to this episodes of a breath holding spell. That is a probable pathophysiology, they say. But most important is, this is not a child trying to draw your attention or making something falsely. A breath holding spell, the definition, by definition, is this one. The benign paroxysmal non-epileptic disorder occurring in a healthy children, usually between 6 months to 48 months, and that's 4 years. So this is the three components you must say: benign, paroxysmal, non-epileptic. Every word is important. Okay, occurring in a healthy children between given 6 to 48. That is how many time after 6 months they may get it. Usually 2 to 5 years, I will say, in a day-to-day terms. How prevalent is it? Is okay. It is very rather 5% of the pediatric population may demonstrate it. 5% is fairly common. Usually boys are affected more. So episodes start with a provocation such as an emotional upset, a minor injury, and then progress into a breath holding spell. Sometimes cyanosis, sometimes a syncope-like attack. So that is a typical expression. We'll see how it progresses actually. There are several types are there. The simple breath holding spell is a very, very common thing. Manifest by holding of breath, usually in the expiration. After deep, take a deep inspiration and take a expiration and then stop. Nothing. Apnea, almost apnea. Usually precipitating event is a frustration or injury. So they ask for something, you don't give, parent doesn't give. Or he falls down and there is a sudden painful episode actually, then starts. And there are no major alterations to circulation or oxygenation. That if you see the pulse oximetry, everything normal only. After some time of breath holding, he comes back to normal. This is called as a simple breath holding spell. The first type, most common. The second one, see, look at the boy, bluish. That is a cyanotic array. It's a dominant type actually, because the previous one, simple one, you may not even notice actually. You just leave it actually. But once you notice it as an abnormal, because among the abnormalities the parents bring to us, the commonest is a cyanotic spell. So the child becomes blue. So it is impossible for the parent not to notice it actually. It is sometimes a part of the temper tantrums. What exact temper tantrums? Next class, Dr. Anusha will tell you. So that is a attention drawing mechanism, temper tantrum. But this may become a part and parcel. So breath holding spell is not intentional, I said. maybe component, usually responsive to anger. Somebody scolds you, huh? Who the hell are you to scold me? Who the hell are you to control me? So this type of a rebellious nature common with toddlers. So because of anger, he's frustrated. He wants to show up. And then may occur, or sometimes may occur with a painful episode also. But painful episodes mostly lead to palliative, the next type actually. So child usually recovers in a minute or two. But because of this minute or two stopping of breathing, so there is some amount of a hypoxia occurs. And after the episode, because he's so tired, he feels sleeps for nearly an hour or so also. So the most important thing is, unlike a convulsion, where there is a postictal phenomenon, here there is no postictal phenomenon. That's important. So that's how it differentiates from seizure. And usually there is no incontinence. And between the spells, suppose today you got one, tomorrow also you got one, in between is perfectly all right. So these points differentiate it from a convulsion, because this is also important, because when you are talking about the topic of convulsion, the differentiation non-convulsive convulsion mimics, they call as a seizure mimics, we call it actually. When I took the class on seizures, I told you. So seizure mimics, one of these example is a breath holding spell. How do you differentiate? Child is in interictal period. That is, if you call this any period as a nictus, interictal period, perfectly normal. There is no loss of there is incontinence unlikely, and the EEG if you take it normal, and there is no relation also, because suppose a child who is doing this frequently, he may get a convulsion. That is, sometimes parents are worried. So there is no relation to subsequent development of convulsion also. That's it, remember. And there is no relation to subsequent development of cerebral injury. Suppose you develop some cerebral palsy or something later on, not because of this. Please remember, this cannot be a cause or etiology for any brain damage. It must be something else. So breath holding spells are, as I said, that by definition, they are benign, whether it is cyanotic or non-cyanotic types. So the simple one you have seen, the cyanotic one you have seen. The third variety is actually the video is not working actually. I can show you otherwise. Let's see later on. The third variety is a pallid one. The pallid typically follows a painful stimuli. So painful stimuli secondary to pain. So it's just like a syncope. In bigger children, you get a syncope. No, it is a vasovagal related syncope. Almost it may lead to syncope. It suddenly falls down, something like that. And usually syncopes happen with a Valsalva maneuver, as you know. So there is one way to test is if you make somebody to test whether the autonomic disturbance is there, make them Valsalva maneuver, suddenly falls down. So this here also, stopping of breath leads to almost like a voluntarily doing Valsalva maneuver, and it precipitates a syncopal attack. Like that, this pallid type of breath holding spells may lead to that type of suddenly become unconscious. Incontinence may or may not occur sometimes. As I said, it's not so common. Child is alert within a minute or so. Immediately they recover. There may be some relationship to adulthood syncope. As I said, maybe adultly, they may subsequently, these children are prone for getting a syncopal attacks, vasovagal attacks when they grow up, actually, autonomic disturbances. So this is a pallid type, because they are called pallid because the perfusion has decreased. It's a peripheral skin. That's why child become pale. It's not that deep so as to produce cyanosis, but the decrease of perfusion make them pallid. The fourth one is a complicated breath holding spell. So out of, if you say in the short notes or marks and the breath holding spell, you tell 4 types are there. One is simple, second is cyanotic, third is pallid, fourth is a complicated. So complicated breath holding spell is a more severe form of the from the 2 most common types, because it's not so common, because pallid and cyanotic are more common. Generally begin either as a cyanotic or as a pallid, whichever it is, but leads to seizure-like activity. But why it's not a seizure? EEG taken while the child is not having spell is still generally normal. That's why, though it may lead to seizure later on, as it is, this is not a seizure because the EEG is normal. So these are the 4 varieties. Complicated may have some relation to the distinct seizure attack. That's why it's called as a complicated breath holding spell. Okay. Now, what exactly is breath holding spell? It's the problem of infants and toddler. I already told you. Child first cries, holds breath. Cyanosis may or may not occur. Sometimes loss of consciousness. Sometimes he may be looking at you, but still he's not, holds breath. Sometimes seizure, as it happens in the case of a complicated seizures. It is a child's attempt to control environment, parents or caregivers. Maybe he's trying to control, but whatever it is, most important is a benign. There is no risk of epilepsy developing because of breath holding spell. These points you must write in the answer. These are the most important thing differentiating from a seizure. Now, one physical condition that may be having a relation because several studies were there. It is iron deficiency, something to do with anemia. Iron deficiency with or without manifest anemia. So anemia may manifest only when there is falls about 11 grams per cent actually. In children, the cutoff is 11 grams per cent of hemoglobin. Then only you can call it an anemia. But even without reading to that level, a deficiency of iron in the body may be one of the causes, because supplementation with iron has reduced the incidence of anemia, because the therapeutic trials are there. So all they proved there is some possibility, especially the palliative types of breath holding spells have something to do with the iron deficiency. And as I said, there is no increased risk of seizures. That's already I told you. So what is the main differential diagnosis is when you take convulsion, breath holding spell comes under DD. So when you're talking about DD, the breath holding spell, the seizures are differential diagnosis, whether it is the seizure or a Chiari crisis. That is in the Chiari crisis, nothing but a suddenly herniation of the Arnold Chiari malformation into the fourth ventricle, to the foramen magnum, the distal, the hind brain herniating into the spinal cord. Dysautonomia, autonomic disturbance, that is a familial dysautonomia as per the sometimes cardiac arrhythmias, because especially long QT syndromes, they all manifest like that, especially CNS lesions. This is one called prolonged QT syndrome. That's what I'm taking. Nothing but this same thing. Prolonged QT you have to rule out. So these are the possible mechanisms which may manifest as, because this is a treatable condition, and unless you address it, it may be, turn out to be fatal also. This is rare, but still keep in mind these possibilities of this. So these are the differential diagnosis. So how do you manage them? Once child comes with breath holding spell, so how do you manage them? You have to help the parents to intervene before the child is highly distressed. That means, the child is prone for a breath holding spell. This is first time it may not be possible, but a child who has been getting this breath holding spell repeatedly, you tell them they avoid this. Prevention is always better than cure. The parent can be instructed to calmly remind the child what is expected of behavior and the potential consequence if the expected behavior does not occur. So instead of pushing him to that level of that frustration, so if you can explain, this is easy said and then done. Actually, I do agree. But a toddler sometimes may not understand, but actually your perseverance and persistence may tell. If a child does not comply, he or she should be placed in timeout. Timeout is one of the commonest behavioral therapies. Timeout means 1 minute. You don't come out, actually go to the wall and stand there 1 minute, until then you don't turn it. That is only punishment. Don't be so harsh actually. It should not be more than 1 minute. And also you should not be in the dark places where the child may get really scared or all those things. But reasonably go to the wall or stand in the corner. So there's punishment. Timeout is one of the best behavioral therapies usually. So up to 10 years, it's very good actually. Very, very small children, the month children, a 1 year child, you may not be able to do, but about toddler age, it is easy. Parents should be always advised to be mindful of their own reactions, how they behave when the tantrum, usually that which secondary tantrums also this works actually. So prevent escalation because of your own behavior. The parents should also be consistency in their behavior is necessary. And they should every time, because he's throwing and falling, actually every time you're obliging is also very dangerous, because that becomes a habitual. And only therapeutic, the pharmacotherapeutic abilities, iron deficiency, because I said iron deficiency has something to do with this. So whenever you suspect this iron supplementation, and the dose of elemental iron when you give is 6 mg per kg and for 3 months, that is a dose. So it is a good dose for iron deficiency anemia also. Please remember 6 mg per kg daily orally may be given in singular divided doses, preferably in the ferrous sulfate salt, because sulfates are easily absorbed, because 20% is a ferrous sulfate availability. That means if you give salt ferrous sulfate, only 20% will be elemental iron. So if you give 100 milligrams, 20 milligrams only the iron is there. That's what it means by. So the dose is 6 mg per kg. You calculate that way. Elemental iron. This dose is not for the salt. So you always calculate iron doses based on the elemental iron. So this is the one. Still VIPs are still coming. Actually, should we lock it or actually I don't know. Srinath, welcome. So we are still coming because how half an hour class is over, and still if you are joining, we should have a little discipline. I know, of course, if you leave later, I don't even know. But as far as possible, try to be in time. Okay, then. So the next one is referral. When the breath holding spell does not respond to patient-parent coaching or accompanied by dangerous behaviors like head banging, where they may injure himself, or severe levels of aggression, that means throwing a temper tantrums, especially because they go together. Such cases, better to send for a psychiatrist, pediatric psychiatrist for evaluation, because they need a higher level of behavioral therapies and cognitive therapies and all this. It's not possible in pediatric clinics. So, when the treatment is, one is parental education, second is an iron supplementation, the third is a referral. So these points, if you write these 3 points, it's more than enough. So guys, that's it. One topic we finished. Very simple topics we have taken today. Okay, and now we go to the second. So now we can unmute in between, and you can just raise any questions in between. Okay. Pavan, unmute yourself.
Sir,
So any questions on behalf of your guys? Have you seen any child doing this? Any youngsters in your house? Any tiny tots making scene? So brothers, children, sisters, children, nephews, nieces, all these things. So what do you see here? A child happily sleeping off, isn't it? So undisturbed. The only problem. So what happened is when child woke up, what the mother saw is, or this one. Did you see the patch? That is the problem. This is called as enuresis, nocturnal enuresis. That is bedwetting in a common terms. Now we go on to the second topic of your today, is bedwetting. So what is bedwetting? Enuresis. Okay. Our first year PGs are also joining, it seems. Okay, welcome. We shall welcome them. They may watch you, how many people you are attended, all of these things. Okay, I don't know whether they joined or not, but anyway, we'll continue. The topic is enuresis. We are talking about this another behavioral. This also comes under one of the behavioral disturbances, yes, but a little more complicated level. What is a nocturnal enuresis? The term enuresis derived from the Greek word enurine, that means to avoid urine. So from that, enuresis has come. By definition, enuresis means involuntary voiding of urine at least 2 nights per month beyond the age of 5 years. 5 years because by which the bladder control is normally attained without any congenital required defects of the urinary tract. So again, as I said, that these definitions are very, 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 very specific. So all of you know bedwetting. Nocturnal enuresis means bedwetting, simple as that. But when is abnormal, it becomes a topic to discuss. It. Every child passes urine in the bed. That's very, very normal. That is a very birthright of a child. But beyond the age when they are not supposed to do that. So what is that age? Approximately cutoff point is this at 5 years. So involuntary voiding of urine. So once in a way, any child may have, but that's not important. So when it happens, twice in a month, at least twice in a month, then it becomes abnormal. Something to be named as the nocturnal analysis. Used because by which time you are supposed to get please pardon me. Some disturbance here. Okay, so that is the definition: involuntary voiding of urine at least 2 nights per month beyond the age of 5 years, by which bladder control is normally obtained and without any. And this is important because there should not be any congenital or acquired defects. If there is defects in the urinary tract, there may be some problem. So you have to eliminate them before you say this is a nocturnal enuresis. That is to be this topic we are discussing now. Now, this, if you see, look at the normal development of urinary control. It happens in steps. The first thing is nocturnal bowel control. Usually children usually they keep passing motion number 1 and 2 in the bed in small babies. So first thing is passing number 2 is controlling, as in even by 1 year itself many people they don't pass unless you take them to the party. They don't pass, at least they show some discomfort faces and all these things by 1.5 year at least, so they develop the potty control. So daytime bowel control. So first is nocturnal control. Only daytime, only when they are awake, only they pass motion. And before that, they will night also they may keep passing motion. So daytime control by nearly 1 or 2 years, actually somewhere around. Daytime voiding control by 1.5 to 2 years actually. I'm getting this. They just make a gestures or actually they stop. Start doing dance or something. Take me to the toilet. There is toilet control. They say 2.5 years. But that is only some people. By 90 to 95% by 5 years. 5 years means actually this type of most of the children. So though the toilet control starts from the second year itself, to say they mention 90 to 95%, it is 5 years. So by 5 years, 90 to 95, that's why we cut off the 5 years. And 80 to 81, nighttime voiding control by 5 years is achieved at least by, because at this, even though they get daytime control, some children may be passing urine in the bed. So nearly 15% only they are not getting it. But whatever it is, the 5 year is taken as a cutoff point. By the way, it gradually keeps decreasing in the adolescent. Only up to 1% children they do not attain that control of the bladder. So this is a normal phenomenon. So all these children who could not control this come under enuresis.
Sir, we can't hear you, sir.
Okay, could you hear this slide? Could you hear?
Yes, sir.
I don't know when it went off actually. So this is the normal development I was telling. Thank you. Just keep a watch on that. Actually, it went mute actually. I don't know how. So the nocturnal bowel control is the first one. To daytime bowel control is the second to achieve. Most of the children by 90 to 95% achieve the daytime void control. That means they were able to tell you. And though nighttime voiding may be not so effective in 10 or 15%, but everybody that's 80 to 55%. But 5 years is a cutoff point. We take it as a to say if somebody is having enuresis or not. And there is another criteria. This is called the DSM, Diseases and Statistics Manual, DSM-5. These criteria, for the examination point of view, may not be that important, but just understand. So, repeated voiding of urine into bed and clothes, whether involuntary or intentional, also is taken. They have taken into the consideration. At least twice a week, or at least 3 consecutive months. They say that the definition is actually even more elaborated. Results in clinically significant distress. Of course, if he's not, social or functional academic impairment, that means child is passing but he's happy, or mother is happy. It's unlikely, actually it doesn't happen. But still, if this passing of bedwetting, all these things leading to some social or psychological or functional, because of this child may get into even behavioral, going to depression, his school performance may fall, all these things, these are the secondary effects. If these are happening, definitely, if this behavior occurs in a child at least 5 years old, and behavior cannot be attributed to the physiological effects of a substance or medical condition. Medical condition means actually that hypospadiasis, that congenital abnormalities, and other condition may be because of substance abuse, because drugs used, all those things. Because if it has happened because of them, we cannot attribute to this normal enuresis. So they are eliminating all these things. Then only call it the DSM criteria for nocturnal enuresis. So broadly, what are the types of enuresis? There are broadly we can divide into two types of enuresis. One is a primary, second is a secondary. Primary means this child has never gained nocturnal urinary control at all. So most of the enuresis are this type actually, but about 10 to 15% are secondary. Secondary means, as I expected with the 5 years or 5.5 years, whatever it is, child attained bladder control and is able to go to the toilet and actually express on him. He is not bedwetting in the night times and all these things. Suddenly, after 6 years or 7 years, suddenly he started bedwetting again. That means because some reason, child who has developed a control of bladder lost it. Such is called as a secondary, and the cutoff period is actually to say 6 months of dry period, because of the last 6 months, the 5 years he developed, I think, let us say up to 5.5 years is okay, 5 and 8 months is okay, then he developed. So it's not like 5 years he developed control and again 1 month he was okay, next month he again develops bedwetting. That's not considered as a secondary. It's a part and parcel of it. Still he's attaining that control. So the 6 months period of dryness is even the cutoff point to say this is a secondary enuresis. Why the classification is different is the management wise a little difference is there. That's why you must identify whether it is a primary or a secondary before you think of what to do with it. So that is the purpose. So broadly primary and secondary. Then so because primary, I said actually it is a well developmental. Secondary causes, we'll see what could be the secondary causes for a child who already developed and now developed again bedwetting. Most often it is a psychosocial conditions. See, psychosocial means some stress factor has happened. This stress need not have to be real stress. Actually, for you and me, it looks a very casual thing. So, for example, a second child is born. It's a good event. Actually, he may be enjoying the child, other thing, but still, there is something a child he didn't expect, that he is not mentally is ready for. So that is a stress factor. A presence of another child who is getting attention from the parents and all these things, and mother has been separated. So even though he is not physically expressing, so even though he likes it, other child, but still it is a stress factor subconsciously for him, and it manifests in the form of a bedwetting again. He starts, a child is previously dry became a night wetting. Family quarrels, father and mother fighting, okay, that's very good. Or father coming and abusing the mother, this type of drunken father, all the broken families, and always, or some other reason. Actually, there is some stress factor quarrels going in the family. It's not mean a child perceives it as a stress, or a change of academic stress. It was a school failure. Suppose he didn't get marks actually as expected, or the teacher has scolded him today, or does not like the class. Simple reason for the change of class teacher. Even such a simple thing actually, or his close friend has been transferred, or he himself has gone to a different school. Simple thing, or change of teacher, change of friends. All these things can be minor, so they look so trivial to you and me, but they can be precipitating factors for a secondary stress. So you have to look for when you're taking history, especially a secondary enuresis, you have to think of all these possibilities. Or this may be because of a medical condition like urinary tract infections, irritation, certainly because of the irritation, whatever it is, especially in girls. And juvenile diabetes mellitus, polyuria, polydipsia, all these things. Polyuria, that itself can be caused of bedwetting again. Because constipation, so habitual, or whatever cause it is, habitual or something. Neurogenic bladder, this is again the disease, actually the abnormality of the dysfunctional bladder. We call it, we will talk under dysfunctional bladder. Structural abnormalities, because those said to define enuresis, we must rule out all these things, but still when child comes, actually, we do not know whether it is really enuresis or not. Actually, you have to think of possibility of being a, it's not because this doesn't come under enuresis, you cannot say that actually this child has come with this complaint of bedwetting. You have to think, rule out structural causes also, like urethral obstruction, major, or if it may be ectopic ureter, something like that. Sometimes major seizures. These seizures may be, mother might not have noticed actually. It's not, if the non-convulsive seizures are there, so they do not know during the seizure episode what happened. Generalized seizure, they lose the sphincteric tone. So it may be part of a seizuric episode that is happening in the night time, which mother and parents might not have noticed. So you must keep possibilities at least in your mind, then only think about this. Okay, because management of secondary nocturnal enuresis depends upon the cause. Unless you deal with that, you are giving simply thinking it is a simple enuresis and keep on telling behavioral therapy or drugs, whatever it is, it doesn't help it actually. So you must rule out all those things, then only they support. Now, so another classification, this is the International Children's Continuous Society, ICCS classification, the very modern classification. If you write, you'll get extra points, but actually this we are teaching the postgraduates. So nocturnal enuresis, primary or secondary, this much already I told you, this much already you are familiar, isn't it? Already, sorry, we are familiar with. So then the next episode is no daytime bladder dysfunction or with bladder dysfunction. That means daytime bladder, what do you mean by bladder dysfunction is either urgency, frequency, or polyuria, all these things we'll discuss later on. So if such things are there or they are not there, so you have, from the history, you have to obtain this thing. Suppose there are no bladder dysfunctions like urgency, frequency, and precipitancy, all these things are not there, then again it's two types. Primary monosymptomatic, that means no other symptoms except for urine passing in the night time. This is called as a monosymptomatic nocturnal enuresis. PMNE is the shortcut called as primary monosymptomatic nocturnal enuresis. So no dysfunctional bladder, primary non-one. Suppose if they are there, if it is yes, this is no, then it's called as a primary non-monosymptomatic nocturnal enuresis is there. So we must put it as actually say yes or no. Let me see. There's something yes or no is missing. Why? So that means there are symptoms again. This child is also having some day-to-day symptoms again. So now it is perfect actually. Yeah. So no daytime bladder dysfunction. That means primary monosymptomatic nocturnal enuresis. No means there are primary bladder dysfunction symptoms are there. Then it is called as primary non-monosymptomatic, because it's no longer a simple monosymptomatic. There is other symptoms are also. So it is primary because since birth, but non-monosymptomatic, NMNE, that is the classification. The same thing classification activity suits for the secondary also. Secondary means there is a period of 6 months of dry period, then he developed enuresis. So with daytime bladder infection, again this dysfunction may with or without this one. So without any daytime bladder dysfunction, it is called a secondary monosymptomatic nocturnal enuresis, SMNE. With symptoms other than there is frequency or such thing symptoms, it is non-monosymptomatic secondary nocturnal enuresis. This is the simple. If you understand the concept, very easy. Until there, it sounds a little complicated, but it's just so simple as that. Okay. But if you want to remember, you write it. This is for additional marks. So we'll talk about the primary. What could be the pathogenesis? Why this has developed? Maybe delayed maturation of the cortical mechanism that allows voluntary control of micturition. You know, micturition reflex is a complex thing because it's a bladder symptom. There is a sympathetic control of the pelvic sympathetic chain and pontine center, main center for the micturition, and the higher center for the control of the subjective control of all these things. So there may be higher symptoms problem here it is. Or a sleep disorder. Enuretic children are usually deep sleepers, we call them. So because of such a deep sleep, they lose control of this possibility. Or a reduced ADH, antidiuretic, because especially the pituitary ADH secretion has decreased. That may be leading to the excessive urination, and that is for polyuria. And the genetic factors, especially chromosome 12 and long arm of 13 chromosome, maybe the probable sites they have got some defect. Speaking of genetics, so why we suspect genetics is there is a big familial pattern is there. familial pattern, the risk of enuresis is 7.5 times more when the father is also enuretic than when the mother was enuretic. So if the father is enuretic, chances of child is 7 times more than a normal child. 75% of both parents are enuretic, and 45% in families with one parent is enuretic, and 15% when neither parent was enuretic. So that is the frequency is coming down. If the parents are enuretic, this frequency is increasing, you see. There is a 68% of concordance, the rare monozygotic twins, and 38% concordance with the dizygotic twins. So all these things indicate there is some sort of a pattern. Some genes and chromosome 22 are also implicated. How they implicated is they may lead to abnormal bladder function. There is for the especially the second types of non-monosymptomatic diseases. Actually, they may be related to that one, or decreased secretion of AVP, that is arginine vasopressin, and arginine vasopressin hormone, that is ADH. Diminished capacity to be aroused from the sleep, that may be his genetic factors, actually, as I said, other chromosomes. So these are the probable mechanisms of the genetics, how it is playing. Now, evaluation. Now, a child has come with a complaints of it, sir, my child is bedwetting, sir. So you must take the history. First thing, as I said, is whether you have deal out the previous. Is it happening since birth or recently developed, or the detailed you have tested? If it is recently developed, when actually he developed the bladder control, that is a 6 months gap is there or not, all to say whether it is a primary or secondary. And is it simply nocturnal or diurnal? Because nocturnal simply you can have because of the polyuria, also diabetic, all these things. If it is diurnal is much more serious, actually much more a complicated process. Is it associated with encompasses? Encompasses is nothing but a not only bladder control, but bowel control is also. But usually much more serious psychological problems are there. That means it requires much more evaluation by the child psychiatrist. Whether it is associated with urinary tract symptoms like dysuria, polyuria, all of you know dysuria means painful micturition. Polyuria is the increase in number of micturition. Pollakiuria means daytime frequency, and hematuria is reddish urine, there is blood in the urine. Pyuria is pus in the urine. So all these things indicate there is some infection or structural abnormalities, some psychological abnormality. That means all these things are point to this secondary enuresis possibilities. There are primary non-monosymptomatic there is enuresis. So these things which require deeper evaluation. You take the developmental history. How is the birth history? Is it premature? Because premature babies are much more likely to develop it. How is the achievement of milestones? Other milestones are also affected, only urinary control. So if it is globally, other things are developmental delay or something may be there. So is it associated with the neurological defects? Then that is a CNS defect may be there. CNS disorders, whether they associated like any developmental defects or actually any structural abnormalities of the brain, all these things are associated. Convulsive disorder is there, all these things you have to see. And take the family history. So as I said, because the concordance with the twins and actually high incidence of the prevalence with the parents being involved. So history of a parents when you were a child, then they may not even remember. Actually, we tell them go and ask your mommy or daddy also. So if their grandparents are there, you ask them actually how is your child. So forget about the grandchild, like that. So traumatic incidents, anything happens, something loss of a family member or actually separation or something, even a small incident, as I said, change of school, such things actually, which may not be traumatic. It will do sound or look traumatic to you and me, but may be very traumatic to this small child. A change of a transfer of a class teacher, that's enough, like that. Parental disharmony, so possible, as I said, the broken families, the children are actually supposed to develop all these things. So this is in the history, you have to develop all these things. So after that, physical examination, how do you evaluate it? So look at the visualization of the urinary system, whether there is hypospadiasis, epispadiasis, any abnormalities in the genitalia, external genitalia. Abdominal examination, because the renal mass is there, or bladder mass is there, posterior urethral valves or something, because and the bladder is full for no reason. Suddenly incontinence occurs with the dribbling, overflow, dribbling happens. So look for the genitals examination, I told you already. And the neurological, because any autonomic disturbances are there, peripheral reflexes are there, perianal sensation, because the cardiac manner lesions may lead to the bladder abnormalities. So the tone of the muscle, the hypotonia, especially lower limb muscles. How is the gait? Because these muscles, the waddling gaits are all these indications of muscular dystrophies. So if you see a tuft of hair in the lower back, that is an indication of a spina bifida culta. So vertebral anomaly, obvious anomalies may be there. The structural or actually where is the meningomyelocele previously operated, such scars, all these things are important for the physical examination to rule out enuresis causes. Now, therapeutic response. Before we go to the management, how do you evaluate when you go for the treatment? So what are the responses a child may manifest? Initial success, that means you given some treatment, whether it is medical, pharmacotherapy or psychotherapy, whatever it is, physical, behavioral therapy. So if the child gets corrected within 14 consecutive days, dry nights are there, that means you are successful. So 14 days, no bedwetting, that is dry day. You have to always maintain a calendar for this. So if there is 14 days of consecutive dry nights are there, that you are successful, the child is successful, that's my initial success. So if it is not there, that is called the lack of success. It's simple as that. So within 14 days, if you cannot achieve after the implementation of your therapy, child has not achieved the dryness, that means lack of success. Then you have to go to the next step. Continued sex means that means okay, child attains dryness. There is no relapse until after 6 months of initial success. So you keep on following this child until 6 months. Child is still dry. That is called as a continued success. But it's not a complete success. You call it a complete success when there is no such relapses after 2 years. So 2 years of dry period is called a successful, that you are successful in treating the child and the child is successful in treating himself. So that is a complete success. And one word that is most dangerous is relapse. Relapse means 2 or more wet nights. So occasionally one day the child may pass you. That's not important. When the 2 or more wet nights within 2 weeks of initial success period, or the interval between the initial success and relapse is measured. So in this period, there is 2 such episodes. It is called as a relapse. So then you have to think, you have to strategize your medical management. So what you have given previously, what you have to do now is it. So to understand the therapeutic measures, I just give the tips. So what are all the things you might have to look for? That is a terminology. So okay. Then coming to the management, what actual management is? General measures and the pharmacotherapy. General measures: avoid excessive fluids, because especially if he's drinking too many, that itself may lead to polyuria in the night time, especially after 7 p.m. Don't give him any fluids and the liquids. Empty the bladder at bedtime. Whatever it is, suppose if he's going to bladder at 8 o'clock, take him just before evening. No, I'm not getting mommy. Even then, take him to the toilet once and ask him to void once. Or if he's going to 10 o'clock, then again, if he is still awake in the bed and actually is not sleeping at 10 o'clock, he's going to sleep. No, why? Go and just void once like this. Ensure that he empties bladder just before bed. Told to wake up at night and use toilet to remain dry. So once when he is a bigger children, you can say whenever you wake up, just go to the toilet. Even if you don't feel like, just go to the toilet because you're awake, and just empty yourself once. Improve access to toilet. This happens, in the olden days. Actually, toilets are kept away from long distance, and all these child being lazy to go till there. So now we attach bedrooms and all these things is not an issue. But even then, you may feel lazy, because see to the child sleeps on the side of the bedroom, because he's turning around the bedroom itself, he feels lazy. So that means make the access very easy, bathroom access. Include the child in the morning cleaning of urine soil, because if at all he soils, see to that it's a part. But no, don't make him shy or anything like that. Make it irresponsible. Let us both clean it. Actually, making a part and parcel of the cleaning. So let us dry these clothes, remove the bedwetting, remove the take a wet mop and actually wiping. Help me in that. So he should be a part and parcel of this thing. But don't ever scold him. Actually, that only again gives negative. So without scolding, making it a part and parcel of your team in cleaning. So behavioral intervention, active participation of the commitment of parents is very important with the child. So the parents should be counseled. These are the points very important for the patients. Encourage the child to win cooperation. Never humiliate or punish. Hey, what is the bloody fellow? Again you cross you. That's no, never. Because this is done by the child without his knowledge. He doesn't want to trouble you or actually give you, or even just showing anger on him. It's just unfortunately without his knowledge it has happened. So no punishment. So if you pass your impression, I give a slap or actually go and do timeout. Timeouts won't work here. See, please don't give timeouts for this type of things. Ensure child doesn't drink, as I said already. These are already I told you. It is a repetition. Reward the, but punishment is bad, but reward is always advised, because if the reward is child is try nights with child, you maintain a calendar. So just a mark, green marks every day. It is dry day, green mark. If it is, if he passes year in that day, a red stamp. You can stamp or marking, pencil marking, or a stamps. You can use all those things. Look at that. So whenever one full week is there, all green marks, then give him a candy or take him a picture or show him whatever you know his play or something. So he should get reward. Reward is always gives fetching very good results. That's why there is one of the most basic thing in the behavioral therapies. So reward him according to whatever he likes. He gives a particular cookie he likes. Okay, make it access to him. So whenever he gives a that day, or you can give him daily also. Whenever you give a green stamp there, you get this cookie that day, like something like. Enuresis subsides in a few months. Actually, just a matter of time, it will go south. That's all. Motivation therapy. Convince the parents the child wants to be dry. Encourage, assume responsibility of his enuresis, actively participate in the treatment. Move from blame for wet nights to praise for dry nights. That's what I said just now told. The praise is more important. A dry morning should receive a positive recognition, should receive a lavish words or praise. Not only praise with words, and also giving reward with the material also. Major breakthrough may warrant material reward. That means that, for example, daily you need not have to give. You just praise him. Okay, you are a great boy, my good boy, you good job, and all these things. And when you complete 1 week, definitely a bigger prize, something like that. That's behavioral therapy. Next is alarm therapy. This is also a type of behavioral therapy. An alarm is triggered. So when the diaper gets wet, to awaken the child from the alarm. This is the electrical gadgets are available. So this is kept in a the sensor is kept in your bed sheet, or actually in the underwear, diapers, and all this. But whenever the urine is passed without his knowledge, the moment it gets wet, the big alarm is rung. So suddenly wakes up. So is a conditional. He suddenly stops it. So he keeps on happening. So within 3 months of treatment, 92% of cure. The only problem is relapse rate. If you stop, remove this alarm again, he can reverse back. That is the main problem. Response to treatment is good, but along with the pharmacotherapy, if it is done, the results are much more better, because only depending upon the alarm therapy may not be always successful, but it is a good behavioral therapy to start with. So this is enuresis alarm occurs actually. You know, the sensor is kept in the underwear. So when the child passes urinary, when they met, suddenly wake up, wake up, wake up. This big alarm comes like this. So this is how suddenly he wakes up, and he, it's like a Pavlov's watch. How his condition is done over the course of time. He gets it conditionally. He stops bedwetting. There are bladder stretching exercises are done with the bigger children. It is possible because daytime increase the fluid overtake. So means until the bladder is full, and ask him to hold it. Don't go, because in the daytime, is only night when he is going enuresis. So until it is a maximum he can tolerate. It's like that daily this doing that, bladder is stretched and its capacity may increase, especially when you are suspecting a small bladder. Holding back urinary until the point of incontinence. So this is bladder stretching exercise. Now coming to the pharmacotherapy, there are a few drugs which can be used. The most important is DDAVP, D-amino arginine vasopressin. For 4 years old and above, this is indicated. So DDAVP, how it works is it reduces the nocturnal urine output to a volume lower than the functional bladder capacity. So that's how it reduces the necessity to pass urine at night. So these useful in those who manifest diurnal rhythm of vasopressin. Do not manifest because they don't have a antidiuretic hormone secretions properly. The dose is 20 micrograms once spray, usually nasal spray. There is oral medication is also available, but nasal spray is much more effective. This a little costly, up to 80 micrograms per day is a dosage actually. You can, that means four applications are necessary maximum, but usually once a BID will suffice. The adverse effects are sometimes may go to hyponatremia, disorientation, and rarely seizures and coma. So these DDAVP dosages, arginine vasopressin, this is the dose of pharmacotherapy. You must all remember that. Apart from that, for those people who cannot afford this because costly, we go for the anticholinergics are available. Oxybutynin chloride is the one commonly used. It acts by increasing the bladder capacity, stretching, and reduce the frequency of detrusor contractions. So indication usually above 7 years is used. 5 milligrams BID or TID. The only adverse effects are dryness, because the anticholinergic, antimuscarinic affects the dryness of the mouth, blurred vision, and facial flushing. These are the 3 adverse effects because of that. You remember that. So these are the oxybutynin chloride. There is another drug, tolterodine. Tolterodine is less commonly, not so frequently available. It is a selective on bladder. Selective on bladder. So it is selective on the urinary bladder, used in patients likely to have small functional bladder capacity, either only at night or throughout the day. So then much more commonly used tricyclic antidepressants are also used. Imipramine is a commonly used drug. It alteration of the sleep mechanism and arousal pattern, and it also has some cholinergic effects. So 25 milligrams up to 6 to 8 years old, and bigger children 50 to 75 milligrams for older children, usually given at bedtime. And the advice is 3 to 6 months, because until you give such a long time, then taper it off. If at all adverse effects happen, physostigmine is the adverse. Adverse effect mainly is anxiety, insomnia, dryness of the mouth, and nausea, and sometimes cardiac arrhythmias and hypotension. So antidepressants are with availability of the GDAVP more, the usage has come down, but in olden days we are used to using imipramine more. So to conclude, enuresis is basically a symptom and not a disease. Intervention is justified for psychological benefit of the child and family. The problem of enuresis should be solved with 5 P's: price, patience, perseverance, passion, and positive attitude. They're the 5 P's. So with that, you will get a successor. So thank you very much. I think we are out of time, in time. Thanks a lot. Okay, 10:30 it is. So stop it now.